McFarlane New Jazz, thank you, Wayne. Another announcement: on Thursday, February 19th, KFAI will celebrate Black History Month with a special day of programming from 6 a.m. to 9:30 p.m. As part of this day of programming, KFAI will be preempting the noon broadcast of Democracy Now! And airing special Black History Month programming from the Communiversity. The Communiversity explores culture, politics, and the kinship between academia and the community. The February 19th edition of Democracy Now! Will be run at 5 a.m. on Friday morning, so tune in all day Thursday for Black History Month here at KFAI. I'm Al McFarlane. You're listening to Conversations with Al McFarlane, broadcasting from the Minneapolis Urban League in North Minneapolis. Our topic today is healthcare. Health disparities is a topic we've been focusing on for a long time. This is one element of that conversation. The particular item today is pay for performance. And we're pleased to have guests both locally and from around the country joining this conversation. Here at the Urban League, Dory Gabolo is the CEO of Open Cities Healthcare Center in St. Paul, and Stella Whitney West is CEO of our neighborhood organization, Neighborhood and Neighbor Organization, a leadership institution in Minneapolis, the North Point Health and Wellness Center. Joining us from Detroit, Dr. Herb Smitherman is the Assistant Dean of Community and Urban Health and the Assistant Professor of Internal Medicine and the Karmanos Cancer Institute at Wayne State University. I understand he's also on the short list being considered for the Surgeon General for the United States of America by the Obama administration, so we wish him well in that consideration. Joining us from Washington, D.C., Dr. Gary Puckrein, who is the President and Chief Executive Officer of the National Minority Quality Forum. Before the music break, we were talking to Dory Gabolo about this question of how do you document what the experience is. And Dory, let me ask you to continue where you left off, talking about documentation.
Well, what I was going to conclude with was that they come into our clinics and take a sampling, which is maybe 5 or 10% of a certain population, and then that's how they determine whether or not you've met the guidance, the requirements. And sometimes that sampling is just not reflective of all the folks that come in. 5 or 10% is not nothing if you have a population of a couple of thousand people. So you're only going to be looking at, maybe 20, 25, 30 charts. And it's just not enough. You have to look at the whole population to really see how this quality component has affected that population.
Dr. Smitherman, what should we be doing to get at cost control? I asked this earlier, I'll bring the same question again. Given the uneven playing field, the fact that our communities have special medical experiences and problems, and if you use the same standard for North Minneapolis as you use for a wealthy suburban community, we're going to end up losing because we won't make the same measurements. Well, in fact, as you say, we may be doing much better, but the bar for measurement is such that we don't reach the markers that provide compensation or performance pay. So what do we do in our community? How do we challenge that strategy or make that strategy reflect our needs, our vision, our will, and our experiences?
Good question. I did want to just pick up one small point, and that is we do have huge health disparities within minority communities and communities of color. And one of the critical concerns about pay for performance is that if you're going to reimburse physicians or provide based on and reward them based on some targets, The concern is that if you have a population that you are caring for that disproportionately has complex patients, physicians may begin to deselect patients, not accept patients because they are complex. That means that their performance rating will go down, and therefore their reimbursement will go down. So these are some very dangerous kinds of
there's a collective
issues that can negatively impact our community.
Doctor, there's a collective here in the audience when you said that. So I'm going to ask you to explore that some more. People, the eyebrows went up audibly when you raised the question about deselecting patients. What do you mean by that?
Well, let's say that you have a lot of very sick, very ill patients, severely ill patients within your practice. You're doing well, you're practicing hard, you're providing significant effort to manage that patient population, but because your baseline starts so much, let's say, lower, and you're trying to reach higher targets, that your performance rating actually for your practice goes down because you're not reaching the performance standards. You already are dealing with an under-resourced population. You are now getting less reimbursement because you're dealing with a sicker population that has standards and quality standards that are lower. And what happens is if you have other providers across the country, it may incentivize them to begin to deselect patients, meaning I'm not going to accept a really sick patient in my practice because it's going to bring my performance standard down, for example. I'm not going to accept Mrs. Jones because she is really a very sick diabetic with a lot of comorbidities, a lot of other illnesses associated with diabetes. So this is, I think, a very dangerous part of performance. And I think when we're implementing systems, payment structures like this, I think we have to be careful because sometimes we will take systems and payment systems that may work in a commercially insured population that may not be applicable across the gamut. And I think maybe the case here. Now, you talked about what are some of the solutions. I think, first of all, we have to cover people. When you have 47 million people that are not within the system, it's hard to talk about quality. How do you talk about quality when 47 million people have no access to health insurance in a real way? And I think the next step is we have to really begin to connect the fragmented system. ER, primary care, hospitals, nursing homes, they have to be better connected. We have to have better management of chronic illnesses, chronic disease. Clearly, have to address health disparities and how health disparities impact this country. If you just take the number of uninsured, for example, as the number of uninsured rise, the number of uncompensated care rises, and what happens is that those funds and those increased uncompensated care is translated into higher premiums. So if you marginalize parts of our society, doing is it actually ends up costing the entire system, American population. Because when that marginalized patient finally gets care, it's usually at the end stage of disease in an emergency room or hospital where the care for that patient, and clearly about the lack of early care, primary care, and prevention, as opposed to late care in the emergency room and hospitals.
We're losing some of your audio, Dr. Smither, but let me ask Stella Whitney West to respond to that, and also Dory Gabolo here to respond.